here today with Boris Malюgin. Boris, in our pseudoexfoliation patients, there's always a concern of zonular instability. Is there steps that you can offer the cataract surgeon in identifying this instability prior to or during cataract surgery?
Of course, we in Russia have a lot of these patients, and definitely you have to start from the very beginning in the examination room. First of all, you have to think about the pupil, whether it dilates enough or not, and this gives you the idea of the stage of the disease. Then you have to look for the phacodonasis to assess the zonular laxity, but many things that you discover during the surgery, when you start the surgery, because sometimes before the surgery it's not so easy to understand how the zonules are fragile, and then when you start doing your capsulorhexis, this is when you're really touching the lens and trying to move it a little bit, and if you see that the lens is mobile, that gives you an idea that there is a significant zonular laxity. Or when you see the star folds, when you touch with your capsulorhexis forceps on the anterior lens surface, and you see these characteristic star folds, this is another sign giving you an idea that the zonules are very lax. The third sign is when you grasp the capsule, and you cannot grasp the capsule because you don't have enough tension on the anterior capsule. Then when you grasp the capsule and you are able to create the flap, then when you're starting your capsulorhexis and you see that the lens starting moving together with your forceps in the direction of your forceps, this is another sign showing you the laxity of the zonules. I will say that in the lax zonules, capsulorhexis is one of the most challenging parts of this procedure.
So now I've identified that my patient has weak zonulars, maybe an area of dialysis. How do you approach securing the IOL in place in these patients?
First of all, when I identify the laxity of the zonules, I should build a plan on how I will remove this cataract, because I do like to use special capsulorhexis hooks that catches capsulorhexis and attach the capsular bag to the limbal area, and that helps me very much to stabilize the capsular bag. The next thing is to decide with regard to the capsular tension ring. We all know that we can expand the capsular bag and stabilize it with capsular tension ring, although the timing of implantation is quite controversial. Some people like to implant it at the very beginning of the case, after capsulorhexis, but in these patients you will definitely compress your cortical material towards the equator of the capsular bag, and you will make removal of the cortex more challenging. So it's a good idea to postpone the implantation of the CTR as late as possible. Also, you should be aware that when you're using capsular hooks and you try to implant CTR when the hooks are in place, the tip of the hooks may entangle with the tip of the CTR, so you have to watch closely how you are implanting, and sometimes removing one of the capsular tension hooks and implant the CTR, and then sometimes reposition the hooks again to catch the capsulorhexis. With regard to your question about IOLs, definitely IOL option depends on the laxity of the zonules. I do prefer capsular approach. I do think that IOL fixation is the best in the bag is the best option. Although we understand that there is a big variation of zonular laxity, and sometimes when I implant IOL and then I see the capsulorhexis is oval, because the ovalization goes in the axis of the haptical elements, and sometimes I do like to implant CTR at this point, although cataract surgery is almost over. But I think that implanting this CTR for the future is quite important, because we know that some of these lenses may dislocate in late postoperative period, and having CTR in the bag will help the surgeon to fixate this capsular bag IOL complex to the sclera at some point when patient will need it.
Boris, thank you so much for taking the time to meet with us today and sharing this knowledge.
Thank you.